Hi, my name is Karen Oakes. I am a nursing student at the University of Texas at Arlington. I am currently enrolled in Advanced Pharmacology, Nursing 5319 with Dr. Linda Grand. I'm here to actually try to present a 3 to 5 minute snippet on vasopressors and inotropes or vasoactive agents. I did put together a slight case study here. Um, about a week ago, I attended with my preceptee. I'm still training a nurse in our unit, and we attended a delivery for a 25-weeker. The birth weight was 670 grams. Baby was diagnosed with extreme prematurity, respiratory distress syndrome, as well as sepsis based on the maternal history. The first 24 hours of life, the baby hemodynamically and metabolically seemed to be just fine, stable, with parameters set are within normal limits. However, by day 2, the baby was trending towards hypotension with low blood pressures with means in the mid or lower 20s. We like to keep our mean blood pressures at or around or above the gestational age number. At 25 weeks, we want a BP means at about 25 or higher. So the baby fell below that. So initially what the doctor decided to do, we decided to give the baby what we would consider a fluid challenge. We give 10 mLs of normal saline as a bolus. It's 10 mLs per kilo. So this baby would have gotten probably about 7 cc's of normal saline, and we give it as a bolus and watch to see if it helps to improve the blood pressure. In this baby's case, it was not the case, so the doctor did order a dobutamine infusion at 5 micrograms per kilo per minute. I'll talk to you about, dopamine. We started dopamine, not dobutamine. Actually, dobutamine is an alpha-1 receptor. It actually works to increase peripheral vascular resistance. It causes vasoconstriction, which of course increases blood pressure. The doctor did order a backup. We had a backup order for dobutamine, which is a beta-1 receptor that we typically will give babies, which helps to increase or improve cardiac output for these babies. Okay. We always give this medication by way of central line because when you give it peripherally, you run the risk of IV infiltration, which can kind of be necrotic, causes burns in babies. So we gave this by way of an umbilical venous line. We never give dopamine in an arterial line. If you consider that, think about how it's such a potent vasoconstrictor. You give it in an artery, it will, of course, constrict the artery, and you can actually compromise the baby's circulation. You know, the babies can even lose extremities when that happens. So we never give it by arterial line. We give it by the venous line, of course. So in many cases, the fluid challenge does work, but in the baby's case, this baby, it did not work. We have to always remember to give these medications safely. These babies are on monitoring 24 hours a day. We monitor perfusion, we monitor their pulses, their blood pressures, their heart rates. Really important to monitor urine output. We like to have it more than 1 cc per kilo per hour if we can for these babies. As far as trying to estimate the cost of care, anytime you're in the intensive care, there's gonna be costs that are involved. You know, the technology that's involved, the skills that's involved. But of course, all of this comes together, hopefully to give us the outcome that we're looking for, which would be stabilization of the baby, overall improvement in clinical status, and eventual weaning off all hemodynamic support medications. If we're able to do that, then we've accomplished quite a bit. Thank you. I know it's short, but thank you so much. Bye-bye.